now we will begin stand, whatever you prefer, the question and answer panel. So the first question we have is actually for Jackie Main, so hopefully we've got her connected. Yes?
Hopefully you can hear me.
You know what, let me jump. We have one for Dr. Pizarro, and then maybe we can hook up with our remote speakers. So for Dr. Pizarro, there's a question. You mentioned infertility, so is there any research for heads in terms of endometriosis and deep infiltrating endometriosis and infertility?
Not very much. There's, again, like with any of these questions, there's always conflicting evidence both ways to say there was infertility or not infertility, and the causes of what that infertility were or were not is always disputed. So I don't know of any conclusive evidence. I don't know if you do.
I don't. No. But hopefully we're, again, in these various projects that we're putting together, getting answers to these questions. So for Jackie Main, I see you are on screen. Would you be able to recommend some resources to share with an OBGYN who's not familiar with EDS or HSD? Jackie,
sorry, could you just repeat that one? I think I'm just getting my
audio going. Okay.
Headphones connected. Yeah. Could you repeat the question? Sorry.
Absolutely. So a question about just resources that you would recommend to an OBGYN or a midwife taking care of somebody who's not familiar with Ehlers-Danlos syndrome or hypermobile issues.
This is a really tricky one, as we all know, and I know for myself it has been received quite well thus far, is that I shouldn't say I am just an exercise physiologist, but writing to an OBGYN and explaining the history of my patient and their symptoms, their diagnosis, what they're going through, and referring to the types of research, Natalie, that you've done yourself, Sally and Melissa, and just stating, these are some of the considerations that we often look at. And with a lot of my patients who have had successful pregnancies, it's been very well received. So I think it would be more so now until we can educate the medical professionals that if you have a really strong team that already understands you and your EDS, that maybe they can start the conversation, and hopefully that is well received.
All right, thank you. So next question for Dr. Russo. The question is just, how is hypermobile Ehlers-Danlos syndrome genetically passed down? And I'll add, and is there a genetic test that one can do for this?
And I think Sally can also talk to this, but for HDS in general, we don't yet have a gene test to do or know the genetic variants that are contributing. So unfortunately, this is currently a clinical diagnosis, and there's not really a way to get information for you or to test the baby.
And then how is it passed down, I guess?
Oh, sorry. It's so we think that it's autosomal dominant, so that means that you have a 50-50 chance of passing it on to each offspring.
Okay, great. All right. And then, let's see, moving around, my questions were supposed to be updated, but I'll just come up with one, because I read Sally's paper with all the interviews and was very impressed with, especially in postpartum care, if you can just elaborate a little further in terms of how do you communicate to caregivers, professional and family givers postpartum in terms of the kind of fatigue that somebody with HEDS or hypermobility might experience much more so than the average mom.
That's me.
Yeah.
Okay. It's difficult because we had all sorts of people telling stories about, being in certain positions for long periods of time, breastfeeding or just doing parental tasks, and then saying, I'm not lazy, but I keep pressing my call button because I can't hold my baby anymore, or I just need help moving position, or I just need this. And of course that can come across to clinicians as, oh, for goodness sake, I'm so busy, why do you keep pressing your buzzer? And it's frustrating unless you do have the background knowledge of what it means to have that hypermobility, increased hypermobility because of the hormones flooding around postnatally, and then you're trying to parent on top of that and recover physically. So I think, again, education is the direction we're going. The clinical decision-making tool can let people know that there's certain things to look out for and be aware of, or anticipate, if you like. It might not be that everyone experiences it, but anticipate that they might. And once they have that understanding, then they can be more proactive about thinking, yes, okay, we're going to anticipate that this person is going to press their call button more frequently because they're going to need that help. Or is there anything we can put in place before they come onto the postnatal ward, positioning tools, positioning aids that will help them and support them in that postnatal period. So again, the online courses that we've put together, and we hope to put together more in the future, will hopefully get that education out to the masses in terms of healthcare professionals. But I think conferences like this, I think the infomercial that we've done gets the message out there. And I definitely see a trend more recently that more media outlets are coming to us and saying, can we please talk to you about this? We want to do an article on the importance of hypermobile Ehlers-Danlos syndrome in pregnancy, etc. So all of that stuff, raising awareness, all of these conferences, all of the awards that are coming out, all of the recognition and the publications, all raise that awareness. And there does seem to be a swell at the moment of awareness and appreciation for this topic and the need for, the hunger for more. So I'm really encouraged by that. And I think that's how we're going to get the message out there.
Great. Thank you. All right. Jackie, you talked a lot about sort of taking off from that, different things you can do once you've had the baby, even in pregnancy. How about preconception? Do you have any recommendations for, getting your body in shape to be pregnant and carry a pregnancy?
Yeah, and as I mentioned, it was definitely one of my biggest regrets, and I think it was more, still working and balancing fatigue and looking after my body in that way after having early bleeding and not doing the exercise component. But, I think I did see one question as well, is that it's very well known that we should try and maintain the same amount of physical activity no matter what that has been, before we've become pregnant or through pregnancy, considering there's no other particular complications. But I would definitely recommend things such as like reformer Pilates. I'm a big fan of Jeannie DeBon and all of her work. So anything that is generally really floor-based, really controlled, that is going to provide that really gentle mind-body connection, stability, is definitely going to be beneficial. So because we do know that onset of pelvic girdle pain, SPD and things comes on quite early, we want to really be working around that lumbopelvic area in particular. And I did just remember there is one article out in regards to POTS and pregnancy. It's only a 2-pager, and it's a very good, simple article that somebody could take to their OB in terms of looking at that homeostasis with autonomic stuff that with pregnancy as well, but haven't noticed anything specifically with EDS.
All right, great, thank you. Yes, I've refreshed my screen and I have about 1 million questions to cover now. But anyway, for Dr. Russo, the next question is, do all people with EDS need a high-risk doctor, and at what point should they start working with one?
I think it's a great question. And I think, I think about access and resources. I think that if you have access, it might be a good idea just to have a consultation with a high-risk doctor, or at least an obstetrician, like as a preconception consultation or some type of OB care provider. And then from there, once they've heard about your individual medical history, can decide if you need to be with a high-risk doctor or not. I have done a lot of consults for people with HEDS, and they can have a really healthy and successful pregnancy with a general practitioner, with a midwife. And so everybody does not need a high-risk doctor, but I think it's important that someone just looks to make sure there are no things where you need special considerations.
All right, thank you. All right, Dr. Pizarro, assigned to you is the question, can you discuss additional concerns or problems that are more likely to occur if the infant also has EDS or HSD?
Well, we haven't looked much into the newborn in this, but it would be more things like positioning, as I discussed. If you're doing something with in general, the baby needs antibiotics or something for a completely different reason, then you're thinking about, okay, how am I going to position this baby? Because if it does have clicky hips or dislocations are going to happen, then I need to mitigate that as much as possible. Also in terms of caring for the baby, documenting any dislocations, any bruising, anything like that, so that you're monitoring right from the start these concerns. And you might not be sure what they are, you're just getting that record started and that diary of events started, so that when they turn 5 and beyond, you can think about, okay, look at the history, what is this telling us, and then make that diagnosis if necessary at a later point. But I don't think there's much else other than being prepared if you're going to anticipate a premature birth, or anticipate potentially a birth where a baby's head might not be in the right position, slightly deflexed, slightly, to the side, whatever, because they've been hypermobile and not kind of strapped in the position they ideally should be in. Then you're anticipating that at all times to kind of think about, what am I going to need? Am I going to need resuscitation equipment? That kind of stuff.
Great. All right, thank you. For Ms. Main, if a pregnant patient has been put on bed rest, how can they exercise to not lose muscle tone?
Yeah. So there are some very, very gentle bed exercises that we can always give patients at, essentially no matter what level they're at. Exercise for a lot of people with invisible illnesses, we know that that's quite a large spectrum. So, it could be doing, for example, just 1 or 2, knee extensions over a small pillow, and they might do an exercise, once an hour, once every 2 hours, depending on, their fatigue, POTS, whatever other comorbidities they have. But there are some very safe, single jointed, single muscular contraction type exercises that we can give in very safe positions to maintain as much conditioning as possible.
Great, thank you, because we have so many people on bed rest that it's very helpful to be able to work with them. We will have a question from the audience, but I have one more for Dr. Russo before we go to the one in the audience. Just a clarification. The question reads, did you say that EDS patients shouldn't have spinal anesthetics? And I guess if you could clarify epidural versus spinal anesthesia, and for example, if somebody's having an elective cesarean section, we're in a hospital, such as my hospital, where they routinely would do a spinal, should the EDS patient maybe have an epidural instead?
It's a great question and clarification. So first caveat that I am not an anesthesiologist, but when you sort of think about spinal versus epidural, the main differences is that it's a straight shot of the medicine versus the epidural is a catheter in the back, and then they sort of put the medicine in. The main things I think about is sort of, what is your cardiovascular health, first of all? Do you have POTS syndrome? Do you have anything else? Because what can happen with the spinal is it can make your blood pressures drop, and then they give medications to sort of bring everything up. So there can be fluctuations in the blood pressure and the heart rate. And again, if there are cardiovascular things or POTS, that can be a little bit problematic, where the epidural is first just the catheter and the medicine can be given in a slower fashion. And that doesn't have to be done for everyone. It really just, again, depends on your individual situation.
Very good. And my follow-up on that is the concern with spinal also is to have a spinal leak develop. So maybe the epidural can help you
Correct.
avoid that. All right. So I understand we do have somebody in the audience who
Yeah,
had a question.
thank you very much. I am a physician, and this was an absolutely outstanding session. And I'm going to bring some tips back that will help, my patients. But I'd like to address a couple of things. This is more medically. One about anesthetic failure, that it typically seems to happen in people who are of European descent. Phenotypically, they're people that have red hair or slightly strawberry blonde hair. And you can mitigate some of that with using a higher percentage, like 2% lidocaine that's buffered. And the other thing which is really important is if someone's going to be intubated. So, people with like Mallampati 1 and 2 airways, and for the audience, Mallampati is a system where you assess how easy it is to intubate people. When you get 3 and 4s, those are the people that are really at high risk of having jaw dislocations, because when we do anesthesia, we like to stretch your jaw as far open as possible, pull it forward to open up the airway. And I usually give notes to patients for the anesthesiologist to avoid iatrogenic dislocations, to really consider nasotracheal intubation rather than endotracheal intubation. And as far as like spinal anesthesia goes, it becomes really important to use a quickie needle tip, and it always want to be really perpendicular to the spinal axis. That way you minimize having a leak that from intrathecal administration of medicines. But this was really just all the presenters were just fantastic. I'm like so impressed by everybody. And so thank you for taking the time to presenting this.
Well, thank you so much for those comments. And unfortunately, we are out of time. Many more questions came in. Please don't hesitate to approach speakers. I'm happy to talk with anybody, and email questions as necessary. I'll turn things back over to Laura. But thank you so much.